G'day, I'd like to let you know that Aussie Med Ed is sponsored by TIGO. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to TIGO and benefited from it. The team at TIGO have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about TIGO, visit tigo.com.au. That's tego.com.au. Did you know that 1 in 16 Australians suffer depression, with over double that instance suffering anxiety? Both conditions are very common and affect social interactions, working relationships, and quality of life. These conditions are something that all medical professionals should be aware of. Today we discuss depression and anxiety within Australia with psychiatrist James Hundertmark. James is a private psychiatrist working at Ramsay Clinic in Adelaide. He trained at the Repatriation Hospital in South Australia and is past head of the Consultation Liaison Psychiatry team at the Flinders Medical Centre and the Clinical Director of Mental Health at the Queen Elizabeth Hospital and the Flinders Medical Centre. He served 2 terms as chair of the South Australian branch of the College of Psychiatrists and is winner of Margaret Tobin Award in 2007 for promoting mental health in a positive way. Join us as we speak to James about this critical aspect of Australian public health. Good day and welcome to Aussie Med Ed, the Australian medical education podcast designed with a pragmatic approach to medical conditions by interviewing specialists in the medical field. I'm Gavin Diamond, an orthopaedic surgeon based in Adelaide, and I'm broadcasting from Ghana land. I'd like to remind you that this podcast is available on all podcast players and is also available as a video version on YouTube. I'd also like to remind you that if you enjoy this podcast, please subscribe or leave a review or give us a thumbs up, as I really appreciate the support and it helps the channel grow. I'd like to start the podcast by acknowledging the traditional owners of the land on which this podcast is produced, the Ghana people, and pay my respects to the elders both past, present and emerging. I'd like to remind you that all the information presented today is just one opinion and that there are numerous ways of treating all medical conditions. Therefore, you should always seek advice from your health professionals in the area in which you live. Also, if you have any concerns about the information raised today, please speak to your GP or seek assistance from help organisations such as Lifeline in Australia. But it's my pleasure now to introduce Dr. James Hundertmark, who's going to talk to us about depression and anxiety and the issue that occurs in Australia. Welcome, James.
Hi, Gavin. Good to see you today.
Well, thank you very much for coming on Aussie Med Ed. It's great to have you on board, and I'm looking forward to hearing about this really important topic. Perhaps we can start off with, first of all, talking about how important depression and anxiety is in Australia.
They are 2 separate conditions, but it's often the case that people with depression have anxiety symptoms. So with a significant depressive illness, it's about 70% of people who also have comorbid anxiety. But certainly using the DSM-5, which is the current version of the classification system we use, we classify the 2 conditions as being quite separate. So we've got a number of conditions coming under the depressive spectrum and a number of conditions under the anxiety banner.
And how do you actually classify these conditions?
So if we wanted to go strictly by the classification system, in Australia, we use the DSM. The current version is actually called the DSM-5 TR. So that's the latest version of the DSM-5. The TR stands for text revision. And the DSM system is almost like a cookbook method for diagnosing mental health conditions. So it will list off the specific features. And then, for example, with a major depressive disorder, you'll need to have 5 of the 8 symptoms that it lists under the heading for major depression. So it's pretty specific in that you need to have so many of a list of symptoms to warrant the diagnosis. By and large, under the anxiety heading, it's a little bit simpler, and there are fewer features to warrant the diagnosis. So the anxiety heading has got panic disorder, generalized anxiety disorder, just a straight anxiety disorder, and also the simple phobias come under that heading too. And OCD, we used to think about as being under the anxiety heading, but that's under a separate heading for most of us now, obsessive compulsive disorder.
So we'll start off with how patients may present with depression. And I always thought of depression myself as a endogenous version or a reactive depression. But perhaps you can explain the different classifications of it.
So I might just start by saying we view anxiety and depression as what we call high prevalence disorders. And that means that they're very common in the community. So anxiety, depression get into that range of 1 in 5. So they're really common in the community, up to 20%. And when it comes to depression itself, yes, we tended to, in the past, think about those two different types of depression, where we talk about an endogenous depression, which was like a depression coming from within, versus a reactive depression in response to a particular stressor. These days, under the DSM system, we don't strictly classify endogenous and reactive. It's more what we call a major depressive disorder. And that's pretty much like the old-fashioned endogenous depression, or what we might call now a biological depression. So it's driven from within. And it's what a lot of GPs might sit with their patients and talk about as a neurotransmitter imbalance. So these days, a lot of GPs will sit with patients and say, you've got a deficit of serotonin. And if I give you this serotonin acting antidepressant, that'll increase your levels of serotonin and help to balance out your mental state. But so if we look at the DSM-5, on the one hand, there's the major depressive disorder, and it's got those 8 symptoms. And broadly speaking, they're things like change in appetite, change in weight, low energy levels, lack of pleasure in activities, loss of interest, poor memory and concentration, pervasively depressed mood, and then some suicidal thinking. So it's those symptoms that indicate you've got a biological depression. And within the DSM-5, there's also a category of what we call melancholic depression, which is an even more severe biological depression. And in a sense, that reactive term lives on in the DSM-5 in that we've got a category of conditions which is referred to as adjustment disorders, which is basically an individual adjusting to a particular stressor. And those adjustment disorders are classified according to the symptoms that come with the adjustment. And one of them is an adjustment disorder with depressed mood. So if you like, that reactive depression diagnosis lives on in the DSM-5 under the term adjustment disorder with depressed mood. Also include things like adjustment disorder with anxiety. Then there's an adjustment disorder, which is a combination of anxiety and depressed mood, and a couple of other adjustment disorders in there. But again, within that depressive heading, the DSM tends to have kind of it's almost like a wastebasket category where if the symptoms don't fit the specific headings, there'll be a depressive disorder not otherwise specified. And so you can have this unspecified depressive disorder if the symptoms don't meet the criteria for a major depressive disorder. And one of the other headings, broadly speaking, under depressive disorder is if the patient has a bipolar disorder and they're in a depressed phase of a bipolar disorder. And by and large, a depressed phase of a bipolar disorder is a much more severe depression than that major depressive disorder. And we, not to try and complicate things too much, but we tend to talk about either a unipolar depression, which is that person who just gets depressed and goes back to the baseline, versus a bipolar depression, where the person will get depressed, but also sometimes go above the baseline and have an episode of mania or a lower phase of mania, which we call hypomania. So there are a few categories there underneath the heading of depressive disorders in the DSM. Honestly, classification in psychiatry is always a little bit arbitrary, but for whatever reason, we've come to use this American system, the DSM system, and it slots people into these diagnostic categories. I mean, one of the important things in thinking about a major depressive disorder versus an adjustment disorder with depressed mood comes into the treatment perspective, in that a major depressive disorder is going to be a lifelong condition. You're going to have relapses and remissions where you get back to the baseline. And also for that kind of condition, we're much more wedded to thinking that antidepressant medication will help that patient. Whereas an adjustment disorder tends to be a milder illness. People tend to gradually pull up out of that, often without any tablets, and often just with a bit of counselling or a bit of supportive psychotherapy, people will get back to the baseline with an adjustment disorder.
Right. And then with severe depression, I believe you also get psychosis attached to it as well. And that's probably more common in the bipolar disorder elements, is it?
It is more common with bipolar depression, but certainly with a straight major depressive disorder, which is not bipolar, a straight unipolar depression, you can get psychotic features. And this will commonly be things like people feeling that there's something physically wrong with them. People will feel very guilty, like pathologically guilty. Sometimes people will feel dirty and like they can't get themselves clean. So it's where your thinking starts to fail, if you like, and head into psychotic territory. And this actually raises, from a treatment perspective, the issue of ECT, of what in the old-fashioned days used to get called shock treatment. And for patients who've got really severe depression that's becoming psychotic, oftentimes ECT is a really good treatment for that condition. And it's going to get the patients better more quickly than persisting with a whole different range of antidepressants and chopping and changing between tablets.
So looking at the major depression causes, you've said it comes from within, and the general practitioner might describe it to a patient as being associated with a chemical imbalance. But obviously, there's a lot of polypharmacy that occurs in people all the time, and some of these medications we use do actually affect neurotransmitters themselves. Is there any associations with some medications that can lead to a depression-type symptoms as well?
Yes, certainly there are some medications, and some quite commonly used medications, that can exacerbate depressive features or sometimes cause depressive features. Probably one of the most common ones would be steroid medications. So steroids can make people go quite flat, or alternatively, large doses of steroids can make people go really high in their mood state. And I've seen a lot of people in the general hospitals, say on a medical ward, who are getting really large doses of steroids. They'll have an episode of mania where they'll really become really quite unwell, be up all night, having all sorts of strange ideas, get very paranoid. And that's often caused by large doses of steroid medications, maybe for rheumatological diseases or renal issues, all sorts of general medical things.
Okay. What about the illicit drugs? Do they have an association with depression as well?
Yeah, I certainly do. And I think really this is one of the things that we've identified with marijuana more and more as the time's gone past, that the chronic use of marijuana, as well as causing what we refer to as an amotivational syndrome, also worsens anxiety and depression. So we know that marijuana causes issues with anxiety and depression. One of the particular things with cannabis or marijuana is that there's a certain proportion of the population who've got a vulnerability towards psychosis. And there's one group that don't have a vulnerability to psychosis and one group that do. And for those people who do have the vulnerability, if they use cannabis, they'll get psychotic. And for some of those people, they'll develop schizophrenia and they'll never recover from that condition. So that's a pretty clear bit of understanding that we've got about cannabis and psychosis now.
Right. And does that become like a depression type of psychosis, or it's just generalized schizophrenia?
Oftentimes it's initially diagnosed as a substance-induced psychosis, but it quite often goes on to be like a straight schizophrenic illness. And that patient develops a schizophrenia, which is often lifelong. it really flags that for some people, cannabis use is really bad and causes a really bad psychiatric outcome.
What's the general sort of route that people tend to take when they suffer depression, and for the average person you might see?
So usually first port of call is the general practitioner, and general practitioners are very well equipped to diagnose and treat a major depressive disorder. So sometimes the patient will come and say that they're feeling flat and sad. Sometimes it might be in response to a particular stressor. A common thing is relationship issues or relationship breakdowns. We'll take people along to the GP. It's also worth saying that sometimes people can present on a number of occasions with physical symptoms. They might have back pain or they might have other sorts of physical symptoms, and they don't actually report depressive symptoms at all. And it's only after the GP goes through and screens for those symptoms that we were just talking about, those 8 symptoms from major depressive disorder, and they can see that the patient actually is depressed. And there then might be a conversation between the patient and the GP to try and get them to understand that they're suffering from a depressive illness. And the next thing that's important for GPs is to do a general blood screen to pick up on some of the issues which are physical health issues which can cause a depressive illness. And the common ones are things like low thyroid function or vitamin abnormalities like vitamin B12 deficiency, or even a really bad vitamin D deficiency could cause a depressive picture. So it's important to do those baseline screens. Usually they'll come back normal, but it's important to do them. And then you'd get on into treatment. And certainly if the flavour of the depression was more like a major depressive illness, GPs would be starting an antidepressant medication. And the commonest ones these days are those serotonin-acting antidepressants. And I gather the most popular one in the market at the moment is a drug called escitalopram, which is about the 6th in line. Originally, we started out with the drug Prozac quite some years ago, which was very popular and very widely known in the community. And now we're on to the 6th iteration of those serotonin-acting antidepressants.
Now, I believe there's also can be some issues with those serotonin antidepressants as well, with some drug interactions. And I believe one of them is one of the ones I might use quite regularly as a pain relief in the form of tramadol. Is that correct?
Exactly right. Yep. So there's a condition known as serotonin syndrome, which is where you get an interaction between various drugs, which leads to too much serotonin in the system. And people get quite unwell physically with that condition. And so because tramadol's got a serotonin action in it, the way it works, that does cross-react with some of these serotonin-acting antidepressants.
So moving on from the GP using medications, are there other modalities you might use with someone suffering from depression as well?
Yeah. So it's often important to involve a psychologist. And so GPs have the ability to do what's called a GP mental health care plan, which allows patients to access psychologists at a slightly lower cost. But certainly it's sensible to involve a psychologist. And just spending a little couple of minutes on psychology, psychologists are trained and certified to various levels. So you could do a 3-year degree in psychology and practice as a psychologist. You might do an extra 4th year honours in psychology, but really the best qualified psychologists have a clinical master's degree. So for that, they'll do the 3 years, the 1 year honours, and then another 2 years of supervised training and end up with a clinical master's degree in psychology. And they're the best qualified psychologists. And normally for someone who's got a significant mental health condition, I think it's important to use a clinical psychologist.
And what would that involve then?
Usually GP mental health care plans are either for 6 or 10 sessions, and then patients might get a second mental health care plan. But it's often the case that 10 sessions is enough for an average depressive illness. So it usually a specific psychotherapy technique. There's a kind of a general type of psychotherapy we refer to as supportive psychotherapy, which is where you talk over your issues. You talk about what alternatives you might use to deal with a particular problem. If you might reflect on things with the psychologist, you might get reassurance. So that's the first type of supportive psychotherapy. Then there's this expression a lot of people use now, CBT. And what that stands for is cognitive behavioral therapy. But really, I like to split the C from the B. And so you've got cognitive therapy, which is focusing on the thoughts that you have in your mind. And the cognitive therapists would say that depression is caused by a whole lot of negative thoughts that get stuck in your head, that are swirling around, and they make you see the world around you as very negative. You feel very negative in that world. And when you look ahead to the future, it seems really negative. And what a cognitive therapist will do is literally get you to write down those thoughts and then reevaluate those thoughts, looking at the hard evidence for and against those particular thoughts. So it's like a very specific type of therapy where you sit with your cognitive therapist, you write your thoughts down, and you'll learn this technique for looking at the thoughts and saying if you're using, in the jargon, if you're using any errors of thinking. So it might be if you're using the error of generalization, where everything seems negative, and because one thing's gone wrong, everything seems wrong. And your cognitive therapist will help you work on those thoughts. So separately and distinctly, there's behavior therapy. So that's the B out of the CBT. And that's not focused on the thinking. It's focused on what you actually do. So a good example of that is actually behavior therapy for anxiety disorders, where you use what we refer to as exposure therapy or desensitization, where you set tasks for the patient, physical tasks, and say if they've got an anxiety disorder related to going on buses, you'll set tasks. Like the first task might be to go and sit at the bus stop for 40 minutes. And the final task in a series of 8 gradually increasing tasks might be to get on the bus and go for 10 stops on the bus. So you've got cognitive therapy looking at the thoughts in your head that drive the illness, and behavior therapy, which is focusing on what you actually do and setting tasks for the patient to do based around behavior.
Okay, so for the combination of the medications and using these various therapy techniques, most people would improve. And then there'll be occasional one that might need to come and see you for an opinion.
That's right. So usually we'll be seeing a patient who has failed 1 or 2 or perhaps 3 trials of different antidepressants. They might have seen a psychologist or even 2 and not responded. And then they come along to us to try and tailor a more specific and perhaps slightly more powerful treatment program.
And how would you address the treatment then for patients who require further help?
So the starting point would be to just review the diagnosis. So occasionally you'll review the diagnosis and you might decide that it's not a true biological depression, and that because it's not a true biological depression, it's never going to respond to an antidepressant medication. More commonly, it is a severe biological depression, and we'll then be thinking about the range of treatments. So we'll be thinking about adding to the medications to get a combination of medications that might work. But we will also be thinking about what sort of psychotherapy we think might help that particular patient.
Excellent. And then obviously you mentioned previously in the more severe cases that have a psychosis attached to it, they're the patients that may require further treatment such as ECT. And I presume that's something also that you may offer in that scenario.
Yeah. And so with a psychotic depression, and sometimes even with a non-psychotic depression, one of the things that we'll commonly do, particularly in private psychiatry, is the patient will usually already be on an antidepressant medication. These days, it's also quite common to use 2 antidepressants at the same time. If I look back 20 years ago, I was certainly a single antidepressant purist. I would never mix antidepressant medications. But now we do that a lot more commonly. And for example, a common combination of medications is to use 1 antidepressant in the morning, that's activating, and 1 antidepressant at night at the same time, that's a bit sedating. And for example, a very common combination of antidepressants now is the combination of venlafaxine, which is a serotonin and noradrenaline acting antidepressant, and we'd use that in the morning. And we combine that with mirtazapine, which is also a dual-acting antidepressant, but it's sedating and you take it at night. It's common for us to use 2 antidepressants. And if the patient's still not responding, and it doesn't have to be a psychotic illness, we also do now use what we refer to as atypical antipsychotic medication. Just to put a bit more context on that, in the past, we had the standard antipsychotic medications, chlorpromazine, haloperidol, thioridazine, those sort of drugs. And say 20 years ago now, we had a whole bunch of new antipsychotic medications that acted in a slightly different way. Just to be a bit more specific for a sec, the traditional antipsychotics tended to have a dopamine-focused action. But the newer atypical antipsychotics also work on other neurotransmitter systems like serotonin and other things. And to come back to the point of a severe depressive illness, we might have a patient on 3 medications. And to use those 2 I mentioned before, they'll be on the venlafaxine and the mirtazapine. And we might add an atypical antipsychotic, specifically a drug like olanzapine. And so olanzapine is a drug that you could use for schizophrenia at a dose of 30 milligrams, but we might use it at 2.5 milligrams or as little as 5 milligrams. And that particular drug really seems to help with a depressive illness. So I sometimes see patients who come to me from a GP, they're really unwell, they're very agitated with their depression, and you give them just a tiny bit of olanzapine and it makes a world of difference, and it helps really pick up that depressive illness and get them back on track.
Right.
And so then if we're talking about a patient who has become psychotic with their depressive illness, we probably already have them on an antipsychotic medication, and it may be the case that they're still not responding. And it can be the case that it almost becomes urgent because the patient can be not eating and not drinking, and they might also have quite intense suicidal thinking. And oftentimes the best way to turn that around is to have a course of ECT.
And that's electroconvulsive therapy?
Electroconvulsive therapy, yeah.
And that involves a general anesthetic?
Yeah, it's probably important to say that ECT is vastly different from how it was even when I started my training. So when I started my training in 1990, it was still a relatively crude operation, if you like. We used to use a little box with 4 dials on it. So you'd be adjusting the voltage and the waveform and the current and the length of the shock that you gave to the patient. You'd have an anaesthetist with you. The patient would get a full general anesthetic. They'd go right off to sleep. You'd apply the electrical stimulus and you'd physically watch the way the patient moved. You'd watch the convulsion that they had, and that would be your measure of how strong the ECT was, if you like. These days, the procedure is incredibly sophisticated. So patients have an EEG, so they've got a brainwave scan all through the ECT. there's a stimulus dosing, what we call a stimulus dosing. So the amount of electricity is very slowly and gradually increased from a tiny amount up to exactly the amount that you need to cause a seizure, because we know that a seizure is the curative issue with ECT. So you've got the anaesthetist there, you're gradually increasing the amount of stimulus, and you then have a series of ECT sessions, which you need to make the patient remit.
So obviously the thought that comes to mind is that, are there any side effects associated with ECT treatment?
Yep, there certainly are. It's like with any treatment in medicine, there are side effects. So obviously you're having a general anesthetic. It's a very short general anesthetic. So all the usual side effects with anesthesia can be there. So sometimes patients will have a sore throat because they've been intubated. Sometimes patients will have headache because they've had tightness of the muscles as they're getting the ECT. One of the side effects that is often talked about relates to memory. The usual kind of memory impairment from ECT is just loss of memory from the time that you're actually having the ECT. And when I'm describing this to patients, I often say, if you were reading a novel throughout the couple of weeks where you had your ECT, you might lose memory of what you read in the novel the night before the ECT or on the morning after the ECT.
That could be a side effect of the anesthesia itself, though, couldn't it?
Yeah, but the ECT often causes that mild, patchy memory loss. Very occasionally, and I've seen this once with one of my patients, there's a term referred to as autobiographical memory loss. And so this gets into a loss of memory for events back over the person's lifetime. And I might also say I feel comfortable enough about ECT that I've let one of my own family members have ECT because I know it's a really effective treatment and people really get better quite quickly sometimes.
I presume, obviously, there'd be muscle relaxant to stop any physical damage they would get with a major seizure.
Absolutely. And so if we go right back into the bad old days of psychiatry, and we're talking around the 50s and 60s, patients had ECT without a muscle relaxant, and they do nasty injuries. And so that's the bad old days. So you have a full general anesthetic and a full muscle relaxant. And if you or I were standing there next to the patient having ECT, you'd only see a mild flickering of the hands and the feet. You don't see any other kind of seizure activity. And the way the strength of the seizure is judged now is on the EEG reading. So it's like on that brainwave reading, the psychiatrist looks at that to see, is it a 30-second seizure? Is it a 40-second seizure?
So if we took across the whole board of people who suffer from depression, the vast majority will respond well to medications, and then some will need psychotherapy, and only a few percentage will come to see you, and even then a smaller number will require ECT. What percentage, and for the listener and the layperson listening, and not to worry them about having to go down this path, the number of people that require ECT will be very few, I presume. Is that correct?
It will be very few. They'd see their GP, they'd respond to maybe the first antidepressant they're offered, and also they might do some quite useful counselling just with the GP. So it might just be a question of seeing the GP, talking about issues with the GP, go on one antidepressant, and their episode of depression will respond.
Now, we talked about some of the medications being associated with depression. What about some of these medications that we're using, the serotonin agonists causing side effects? And I know the antipsychotics in the past could have associations with Parkinson's.
Yeah. So the way it's evolved historically is for a long time, we pretty much just had tricyclic antidepressant medications. So when I was a registrar, to start with, all we had was tricyclic antidepressants. And we would pick a tricyclic antidepressant through the range. And specifically, it was things like the cholinergic side effects. And the one that had the strongest cholinergic side effects was amitriptyline. And you still see that drug around mainly in the chronic pain space. But so with those tricyclic antidepressants, we used to see a lot of side effects with constipation, dry mouth, blurred vision, postural hypertension, that sort of thing. And then the serotonin-acting antidepressants, Prozac in particular, came onto the market. And the drug companies initially were saying, they've got none of the bad old side effects, these drugs are really good. But in fact, like all drugs, they've got side effects. And the common ones are things like agitation. So some patients taking Prozac or Zoloft or any of the serotonin drugs get really agitated. And a small percentage just get so agitated they can't tolerate those drugs and they have to use another class. Gastrointestinal side effects are really common with the serotonin-acting drugs. And the other one that kind of emerged at that stage was sexual dysfunction. So this is loss of libido, difficulty getting erections, and delayed ejaculation, and for women, anorgasmia. And so that class of side effects emerged as an issue with the serotonin-acting antidepressants. And since then, there have been a number of other classes that have come in, and some of those classes, for example, have a very low incidence of sexual dysfunction. So some of those other newer drugs are preferable if you've got a patient who's particularly concerned about sexual dysfunction.
We talked before about the use of dopamine medications that affect dopamine function. Do Parkinson's medications also have any influence on either incidence or the reduced incidence of depression?
The issue with dopamine in psychiatry probably more relates to psychosis, because we know that Parkinson's disease is about a deficiency of dopamine. And when we're trying to treat Parkinson's disease in medicine, we're trying to give drugs that increase the level of dopamine. Whereas with psychosis, the traditional model of psychosis was that there was too much dopamine. And those original drugs for treating psychosis would reduce dopamine. And that's where a heavy dose of antipsychotic medication would look like Parkinson's disease in some patients, because you were really pushing down their level of dopamine, and they'd start to have tremors and other symptoms like what we know as mask-like faces, which look like Parkinson's disease. And the opposite is the case too, that a medication for Parkinson's disease can actually in some patients cause psychotic symptoms. So it's that dopamine dimension from being too little and being associated with Parkinson's, or too much and being associated with psychosis.
So we've got the serotonin sort of pathway for depression. We've got this dopamine pathway with psychosis and Parkinson's. So where does the noradrenaline medication come into it then?
The noradrenaline hypothesis was another hypothesis in the treatment of depression. So that was a hypothesis from the 60s, where they felt noradrenaline was important in treating depression. And those tricyclic antidepressants and a couple of the other more modern classes work on the noradrenaline system. Personally, my own view is that we really know very little about neurotransmitter function, and we're still in our early days of understanding the brain. And the brain's incredibly complicated, and there are millions of neurons, and there are multiple different neurotransmitters, and it's just incredibly complex. And sometimes people will say, do you think there'll be a time where psychiatry will be dead and you'll all be neurologists? And to that, I would say no. I think the brain is so complicated that there's always going to be a space for us in psychiatry, because we're sitting there between science and art, if you like. It's a mixture of the two things. And I don't think we'll ever be able to say, look, this is Gavin, this is his brain, this is how his brain works. We'll give him exactly this drug and we know it'll fix this issue. I don't think we're ever going to get there.
Yeah. On that point, I was going to ask about the other things like autism spectrum disorder or personality disorders. Are they associated with depression or anxiety?
So if we take personality disorders, And in particular, if we take the condition known as borderline personality disorder, that is a condition that has a very strong mood, or we use the term affective. There's a very strong affective component. And people talk about borderline patients as having affective instability. They really struggle to regulate their mood. And what you tend to see is it's almost like a type of bipolar disorder, but the shifts in mood are really rapid and could happen 10 times within a day. So at one moment, they might feel angry. Another moment, they might feel sad. Then they might feel really deliriously happy. And for borderline patients, we're inclined to think they actually have trouble identifying what their moods are. Sometimes they get confused, like they feel themselves really full of emotion, but they can't identify what that emotion really is. And one of the things that people probably know about with borderline personality disorder is one of the core issues for them is they get a lot of suicidal thinking. They have a lot of thoughts of deliberate self-harm. So they get trapped into this strange way of dealing with their mood.
There's another area altogether, and another topic for a podcast another time. What about with autism? I thought I'd read somewhere with some association as well.
Certainly what we're seeing in psychiatry at the moment is there's an explosion of diagnosis in the area of autism. And there's also a huge amount of diagnosis happening in the area of ADHD. And those two conditions are taking up a huge amount of time as far as referrals to psychiatrists and treatment in particular for ADHD. And both of those things are just so much more common now than they were 15, 20 years ago, that we have to almost sit back and have a rethink and try and understand what's happening in the world now that makes autism and ADHD so much more common. And one of the differences now is that 20 years ago, people would come to the psychiatrist, would do a diagnostic interview, and they'd say, I think you're having a major depressive disorder. Now the patient comes and they say to you, I've got autism, or they say, I've got ADHD. I've been online. I've done some surveys. I know I've got ADHD. Can you treat it for me? And it's turned on its head from how it used to be. And right now, people with ADHD will tell you they can't find a psychiatrist because the demand is just so huge at the moment. And I really personally, I can't explain why that's happened, but it's just very common at the moment.
So do you think there's any association though with depression on that side of things?
I don't think so.
Now, moving on, what do you think the future holds for treatment of this? Do you think there's much on the horizon that looks promising for further treatment and new types of drugs, or is it still a evolving specialty that we're still trying to get to grips with it all?
I think one of the important things is the way people get in touch with services is changing. And you might broadly use the term mental health literacy. I think people in the general community are becoming more and more familiar with mental health issues. They know that depression and anxiety are common, and I'm hoping that there's less and less stigma there so that people feel more and more comfortable to go along to their GP and talk about it. And one of the other things that's becoming really common is internet-based treatment. So to give you an example, there's a website, and so what I can do with patients now is I can see them for the first time. I can go to this and I can enroll that patient, and they'll get a message come into their email address. And I can also make it so that they don't have to pay anything, and then they can do online treatment of their condition. And so if they've got a depressive illness, they can use the online pathway and gradually click through. It's almost like a set of slides online that they can do. And it's often a cognitive therapy approach that gets used. So instead of me trying to take them through a cognitive therapy program myself, instead of a psychologist having to do it, they can actually do a self-paced internet approach to treating their depression with a cognitive therapy, which can be really helpful. And just to expand on that a little bit more, I've got a patient right at the moment who's using This Way Up. And if they have a lot of symptoms on a particular day, there's a little flag that comes up on my email inbox. And I know that it's sensible to give that patient a call and have a chat and just see how they're faring. So that kind of internet-based treatment is a new and emerging area.
So it's an adjunct to support your management as well. Is it something that people would use spontaneously on their own without having seen someone? You'd probably not recommend that, I would assume.
Yeah, I think that's a good point, because for us, a lot of the time in mental health, the bottom line is safety. And we want to know that the patient is safe. So we want to know that their condition's under decent control so that they can use an online approach, and that there aren't still safety issues that we need to get across.
Yeah. Excellent. And last thing of all, what about lifestyle change for depression particularly? I've read that the natural endorphin release from doing exercise is also very good for you and takes your mind off the worries of life. Is it a myth, or is it a true factor that, good health and eating well and exercising regularly is a good thing for you? I know you and I both enjoy our music, so that's one thing that takes our mind off it. But what about general lifestyle and other factors?
Yeah, I'd probably mention 3 things: alcohol, exercise, and diet. One of the really big issues in mental health is alcohol and other drugs, but in particular alcohol. You tend to see with some people, and it's particularly men more than women, that when they're struggling with their mental health, they tend to drink more. I do some work in the Northern Territory. When I'm up there, I'm staggered sometimes at how much alcohol intake patients have. And when their mental health deteriorates, it escalates. So I'm often trying to get people to reduce their intake. I'm often talking about trying to have alcohol-free days to start with, and then gradually attempt to cut back. So it's really important to monitor your patient's alcohol intake. And certainly exercise is very important. And I'll sometimes say to patients, look, if you exercise for half an hour 3 times a week, you'll do way better than other patients who are not doing any exercise. So exercise is very important. I have a lot of patients who tell me they go to the gym, they exercise, but the other thing they do while they're there is they chat with people. And so going to the gym becomes a social as well as a physical exercise activity, which is really helpful. And thirdly, as far as diet, just at the moment, there's an Australian psychiatrist who's really tuned in on the Mediterranean diet. And she argues that the Mediterranean diet in particular, so we're talking about olive oil, tomatoes, all those things that are eaten in that area of the world, that's particularly useful for people with a mood disorder. So she thinks that's quite important for people.
That's truly amazing. There's so much more we could cover. So it's been brilliant speaking to you, James. Thank you very much.
Excellent. Thank you, Gavin. No worries.
Thank you very much for listening to our podcast today. I'd like to remind you that the information provided is just general advice and may vary depending on the region which you are practicing or being treated. If you have any concerns or questions about what we've discussed, you should seek advice from your general practitioner. I'd like to thank you very much for listening to our podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and TEGO, offering medical indemnity insurance for doctors. That's tego.com.au.